Um, First question is not how to address, but do we need to address the fibula at all? And as you can see, there is rather conflicting evidence about that. There is evidence from some studies, all not level 1 studies, that there's a risk of non-union of the tibia if the fibula is fixed, and of varus malunion if the fibula is fixed rather than when it's left alone. But this is not high-level evidence. A recent review from 2015 has concluded from several studies that there is no negative effect of fibular plating, but also no advantages. And the only significant difference was that patients who had the fibula fixed had more implant removals at the fibula. Then we have several studies that showed significant superior results with the fibula fixed than with leaving it unfixed. And there's one study that even shows higher rates of infection, which is quite a big deal, considering that pilon fracture is already a fracture that is always accompanied by severe soft tissue damage. So several authors recommend fixing it, but one should be aware that the fibular fixation does not preclude a good tibial fixation. There's one very interesting study about the pathanatomy of the fibular fracture. Of course, a pilon fracture is always axial impact, but you always have varus or valgus component to it. And those authors found out that with varus stress, you have a slightly oblique or straight fibular fracture. And these fractures tend to fail if you just plate the tibia laterally. Of course, the fibula is addressed in these cases. And that with valgus stress, you have a higher chance to have a comminuted fibular fracture. And in these cases, the risk of failure for the pilon fracture is higher with medial plating. They found it out in their own series. So the pathanatomy is different, and of course it makes a difference if you have a straight or oblique fracture or a comminuted fracture that has fractures on several levels. And the next question is when to fix it. And in Germany, it was for a long time usual to fix the fibula first. So typically in staged procedures, the patients come in, you straighten out the fibula and the tibia in the external fixator to have some ligamentotaxis, and then particularly if you have a simple fibular fracture, is it fixed the night of admission. But there's absolutely no evidence that this is needed. And the biggest problem is if the surgeon who fixing the fibula is not the surgeon fixing the pilon later, you might hamper your later approaches and your plan for fixing the tibia. So only the surgeon who really has a plan or will do a plan to fix the fibula, the tibia and the tibia pilon should be the one fixing the fibula in the first place. If not, you don't do the second surgeon a favor when fixing the fibula. In best, you don't cause any trouble, but of course you can cause trouble both with an approach that is there in a vulnerable soft tissue and also with malreduction. So particularly if you have a comminuted fibular fracture, it should not be fixed first. And there's absolutely no reason to do it the night of admission. External fixator will straighten out the tibia and the fibula. There's no need to put an additional plate on. And here is an example. It's the same patient. And as you can see, the fibula has already been fixed. And if you plan your approach, if you would like to do an anterolateral approach, this would be very close to the fibular approach. Luckily, in this case, you would not go for an anterolateral approach because you end up straight on that big fragment. You would not go for a medial approach. You would go for a central approach. And this has a nice distance to the fibular approach that's already there. But if you would plan for an anterolateral approach, you would have a problem with very close incisions. So you see the final surgery, the definite surgery, and this has a reasonable distance to the fibular incision. But if you plan another approach, then you could have a problem with that. And another reason for not always being helpful is that if you have a fibular plate, then the overlap of the plate with the joint contour might be a problem when controlling for reduction. Of course, you will also have a femoral distractor and have a look at the joint itself with distraction, but it is not always helpful to have a plate already on the fibula because I personally like to have a mobile joint that I construct first. If I go for joint first, and then after joint reconstruction, adding the fibular fixation. So here this patient with a reasonable distance between the two approaches has nice soft tissues. At 10 days, you see the fibular incision is almost healed. So in this case, at least it didn't cause any trouble. And this is the same patient 8 years later. He came for hardware removal and removal of those osteophytes, but otherwise he has a good result considering the severity of injury. Here we have another patient, skiing injury. So these were the Swiss Pilons, the big series by Reilly and Allgöber in the 60s and 70s that always had good results with primary plating. Here you can see we have a comminuted fibular fracture and a relatively easy tibial fracture. In these cases, of course, the tibia is fixed first and is in this case fixed with a MIPO technique with direct vision of the lateral joint, the medial joint space here. And then the fibula is, because it's comminuted, as you can see, is fixed second with an open approach. And here another patient with a CE3 fracture, and this patient benefits from an anterolateral approach. So in this patient, fibular approach directly lateral would not be very helpful in the first place. And so we went for the anterolateral approach to get into the fracture, fixing the joint under direct vision. So I like to have a mobile joint block to be able to manipulate the fragments, reconstruct the joint, and then as a second step, I can do the fibula, or even as a third step after fixing the tibia. In this case, it helped me because it was a simple fibular fracture. A simple fracture helps you with getting it out to length and straight, and then it helps tibial reduction. If you have a comminuted fracture, it does rather not help you with tibial reduction. And here we have a valgus impaction, as you can see, with comminution of the distal fibula. In these cases, it's absolutely not helpful to start with the fibula. Here, the patient was fixed because it was a relatively large joint block with intramedullary nail and screw fixation of the tibial platform, and then fibular fixation was added next. So summary, there is no general recommendation if the fibula has to be fixed at all. Many surgeons do it, including myself, to enhance stability, but you have to admit there's a higher risk of infection, and sometimes, but I think only if you did not reduce the fibula very well, there might also be a higher risk of non-union. I have not seen that in my experience. Primary fibular fixation, NITAD admission, is absolutely not necessary. And you have to be careful. The fibular approach should not preclude approaches that are needed later for fixation of the pilon. So if someone chooses to fix the fibula first, it should be the same surgeon who is also performing pilon fixation. Otherwise, you can run into trouble. With a simple fracture, it may be helpful to fix the fibula first to aid with tibial reduction. In comminuted fracture, the pilon should absolutely be fixed first. But even with a simple fracture, I sometimes, or most of the time, start with joint reconstruction to have a mobile joint, to have the option of distraction. And after joint reconstruction, you then can still choose to fix the fibula or the tibial shaft first or second. Thank you very much for your kind attention.